So Dr. Chitra Ramamurthy, who's a dear friend and senior, she's going to be talking on when to offer PRK Extra, and after that we have a talk on PRK itself by Dr. Pooja Khamar from Narayan Netralaya to wrap it up. So please go ahead, Dr. Chitra.
So first and foremost, I'll start my talk saying, very happy birthday, Gaurav. That's the kind of friend he is that he wishes me a post even before I won the elections. So I know if I have such friends, sky is the limit I would reach. So a very happy birthday. So my due in the next few minutes is to when to offer PRK Extra over others, but I'm going to give a summary of everything so that we can decide together what we want. We all know now that extra procedure means combining laser vision correction with cross-linking. There has been extensive literature research which has been done. There have been only encouraging facts which have come forward. There has been nothing very drastic or daring about it. But what comes through is that you need to refine protocols because there are different people are using different protocols, and it is important that when you accept something as a way forward, probably, it needs to be more stable and consistent. As was discussed by all my previous speakers, whenever it's a very high refractive error or a thin cornea or a borderline topography or allergic manifestations like grubbing or keratoconus history in the family or pregnancy, these are times when you stop and wonder whether you can do a laser vision correction on the cornea of these patients. It might appear that you will be able to leave a 300 micron residual bed for these eyes, but then there is a certain doubt about some minuscule nuance in the topography which is not appearing okay. We also know that a feature of biomechanical weakening of the cornea can express as ectasia, could also be regression, which is actually a different remodeling of the cornea, which is not planned for. So for this, there were different cross-linking procedures which have come forward along with each of these cornea-based procedures. It is just that one thing which has come across is they are safe, they are efficacious. There is the refractive accuracy, there's no change in refractive accuracy, but what is the amount of cross-linking? The favorable points is ectasia, the actual percentage now with the kind of understanding we have of topographies is just 0.02 to 0.6. Genetic expressions have indicated that there is also a low expression of lysyl oxidase in some of these eyes, which could contribute to either ectasia or regression. So what are the actual concerns? Why are we discussing whether to combine cross-linking is? We all know with the regular cross-linking, there's some flattening, there is compactness of the lamellae, which is what we believe gives stiffness to the cornea. There could be a mild haze, there could be a refractive impact for some of these eyes. But then, none of these happen if you use a low energy fluence, and only thing, the biomechanical tool to understand whether the cornea became biomechanically strong is still dubious. Like all that we have with us is Aura and Corvus, and we are not 100% clear whether the Corvus is right in all times. So based on the different published data, we know for PRK, you debride the epithelium, you do your ablation, and instead of 0.1, you would use 0.22 to 0.25 riboflavin you would use. In our setup, we would apply these drops for 90-second soak and then irradiate so that you have a 2.7 millijoules. That is, it would be 30 milliwatts for 90 seconds again. But there are some people who have used 5.42. Finally, anyway, majority do stick to 30 to 45 milliwatts and a contact lens is placed. Otherwise, the follow-up is similar. Now, when it comes to LASIK Extra, you actually fold up the flap and then do cross-linking on the stromal bed. Because the flap, if it's exposed to the riboflavin, there could be flap shrinkage can occur, there could be striae on the flap, so you need to keep the flap folded and protected. Again, the energy protocol should be largely 30 milliwatts or 90 seconds with about 2.7 millijoules, but there is, again, variables in the different studies and there's no consensus. For SMILE Extra, pocket of crosslink, riboflavin placed in the pocket, but the irradiation is transepithelial, which has to be kept in mind. So then, ectasia, the follow-up has been minimal, but for regression, what we understand is by doing cross-linking, there is better biomechanical strength, there's reduced corneal epithelial remodeling. There have been 10 to 12 papers on myopia, 3 papers on hyperopia, and some more on extra, which all have shown that there has been no refractive impact. The very encouraging point was in the hyperopia study, there were eyes which were followed up for 3 years. It was seen that those eyes which underwent hyperopic classic with cross-linking, they had more stable refraction with no regression which was happening. This also was encouraging in Smile Extra, though there were a few who have used very high energy as if they were doing for a regular keratoconus eyes. But it is important for us to stop and understand that we do not use the conventional method, but we use accelerated cross-linking because the amount of flattening in haze we know is very minuscule in that. We know that LASIK flap is not going to contribute to the biomechanical strength, so you wonder how effective doing LASIK Extra with LASIK is. With the Smile, the epithelium is intact. Even though you have left riboflavin in the pocket, the cross-linking is through the epithelium and there is less of oxygen. So then you also understand that there are many people who say just doing PRK alone is also enough because there is some inflammation and there is tightening of the stromal lamellae. So do we need to combine a PRK Extra with PRK? But logically, whatever studies have come up says that PRK seems to fare better than Smile, than LASIK. So if you're doing cross-linking, it makes best sense to do PRK Extra for these cases. And then, of course, there is no adjustment in nomograms. Mitomycin C has to be used to prevent the haze because of the migratory fibroblasts. There is no flap linkage. And because riboflavin diffusion occurs, in these LASIK Extra flaps, the flap adherence is better. There are hardly any cases of keratitis, DLK, or keratopathy. So, but the final thing which remains is, when you talk of biomechanics, you don't want tissue subtraction to weaken the cornea. LASIK Extra, there's vertical cuts, which is not good. Smile Extra, there's delamination cut, but even that does bring down hysteresis. With PRK, you're disrupting the Bowman, which is contributing maximal to the tensile strength. So then you wonder, in those very borderline corneas, do we do a PRK Extra at all, or do we go ahead and do a phakic IOL for these patients? But when it comes to regression management, every study has been very encouraging that it definitely seems to address the epithelial hyperplasia. So then, having seen it all, there have been different studies, 6 months, 1 year, 2 years. Nowhere there was a loss of BCVA. No, there was no increase in flattening. There was, in fact, gain in lines in some eyes. There was no endothelial haze. Some of them had temporary haze. They have used abnormal energy protocols. So what you can understand, this was our study where we have compared 118 eyes with 109 eyes. And what came through when we compared PRK Extra with PRK was that they continued, both the studies, the results were stable. There was stability in the refraction. The mean K was also comparable. So one thing definitely comes across, that PRK Extra is not going to be do harm. And possibly a role of MMC should be there when we are doing PRK Extra. Thank you very much.
Thank you, Chitra ma'am, for very comprehensively covering the topic. It's a very important topic.